Okay. All right, so we left off with the thyroid hormone, and we will go back. She certainly does. I guess they got like new bikes, and then there was a collision between the two of them, and then one person's bike isn't um, working as well, so now I have to fix that. So anyway, um, here we are at adrenal function. So you'll notice that there is a lot of slides on here. There's other endocrine function. We're not going to talk about all of the hormones that are produced by the hypothalamus and pituitary gland, as well as the sex hormones, but though that information I believe is still attached in terms of the menstrual cycle and spermatogenesis. Those things are still here. We are going to just there for your information, but we are going to talk about the adrenal glands hormones, and those have the possibility of being on the exam, and they're on the study guide. So the adrenal gland is a complex organ located on top of our kidneys. Inside is the adrenal medulla, and that does produce and can be stimulated to produce epinephrine and norepinephrine as part of the sympathetic nervous system response. The outer part of the adrenal gland, the cortex, is the part that makes some of the hormones. Some hormones, and we've talked about one of them already, which is aldosterone, when we talked about the cardiovascular system and when angiotensinogen was converted to angiotensin 1 and then angiotensin 2, and angiotensin 2 activated receptors on blood vessels that cause vasoconstriction, and then angiotensin 2 also activated receptors on the adrenal gland, which prompts the cortex to produce aldosterone, which we know helps to save sodium and water and release potassium in the distal convoluted tubule of the nephron. So we've already learned about one of the adrenal hormones. The other one is cortisol, which has it also is part of the inflammatory process, the metabolic process, and our stress response. And then the adrenal sex hormones, androgens, is a source of androgen, the main source of androgens for women, but also a source of androgens for men as well. So cortisol is our stress hormone. It does also help catecholamines and the catecholamine response in the setting of trauma and extreme stress. So the presence of cortisol enhances the effects of epinephrine and norepinephrine. It's an anti-inflammatory in order to suppress the immune function. This is done because during stress, we want all our energy to be related to utilization of resources in order to feed our metabolism and help and support our vital signs. So we don't want excess functions that aren't necessary for survival at that very moment in time, because we always have to remember that the body is made to handle stress such as dehydration, starvation, and trauma, not pharmacology and pathophysiology class, etc. There is a feedback loop again involved here. It's just that the level of cortisol is different. It's hard to track because cortisol itself goes through its own circadian rhythm. We always have fluctuating cortisol levels within a 24-hour period based on our sleep-wake cycle. We will have fluctuating levels depending on what sex you are, if you're during a time of growth and development, if you're during a time of stress, then those levels can be higher. It's not as easy to find the normal level for somebody. the way this works, again, is a hypothalamus pituitary hormone end organ axis. So it's the hypothalamus releases corticotropin releasing hormone, which stimulates the pituitary gland to produce adrenal corticotropin hormone, which stimulates the adrenal gland to produce cortisol. So I'm sorry, the cats are fighting right now. Okay, so if a person has trouble with cortisol, they could either have too much cortisol or too little cortisol. So in the setting of what is called adrenal cortical insufficiency, or a decreased production of cortisol, it could be an actual primary adrenal cortical insufficiency, meaning it's the adrenal gland. There's an autoimmune process that's decreased function of the adrenal gland. So even though the hypothalamus is releasing corticotropin releasing hormone and the pituitary is releasing adrenal corticotropin hormone, it doesn't matter because the non-functioning adrenal gland will not be able to produce cortisol. That's primary adrenal cortical insufficiency, Addison's disease. And so we would expect that ACTH levels are elevated because there isn't inhibition of that feedback. Secondary adrenal cortical insufficiency occurs in overall hypopituitarism. So same as with the thyroid gland, you can have a decrease in production of all of the hormones of the pituitary if it isn't working on its own. So it is difficult for people who have a decrease in cortisol. Their main symptom is fatigue, but they also have weight loss, potential decrease in appetite, and hypotension, and hyponatremia. So this part is sometimes can be difficult to understand, but you have to remember that part of the adrenal gland is the production of other hormones, including aldosterone. So people with an overall adrenal insufficiency will also have a decrease in production of androgens and aldosterone. And aldosterone is supposed to save water and sodium and get rid of potassium. So if we don't have a functioning adrenal gland and are not able to release the appropriate amount of aldosterone, then we can expect a potential increase in potassium and a decrease in sodium because of the aldosterone. So here's our hyperkalemia that we would expect. We should expect a deficiency of some of the androgens, and hyperpigmentation, which means darkening of the skin or the gums. And the reason that occurs is that adrenal corticotropin hormone is closely related to the precursor of melanin. And so if there's an increase in adrenal corticotropin hormone, there's also an increase in circulating melanin. So people tend to have darkening of the skin. So that's Addison's disease. The adrenal gland, there's an autoimmune dysfunction of the adrenal gland, which means there's decrease in release of all of the hormones of the adrenal gland, including cortisol, as well as androgens and aldosterone, which account for the symptoms that the patient might be experiencing. And the patient will then need to be on replacement of those hormones to maintain normal functioning. The other side of things would be an increase in cortisol release because of usually related to an adenoma or some kind of tumor that is increasing the production of either cortisol in the adrenal gland, or there's a tumor in the pituitary gland that's increasing production of ACTH. Sometimes certain cancers can produce hormones that they don't normally make. So especially a cancer that is very non-differentiated, meaning that's very different from its origin. This is very common for small cell lung cancer, which doesn't have anything to do with the pituitary gland or the adrenal gland. Some small cell lung cancers will produce ACTH, leading to an increase in cortisol and other symptoms that aren't related to the cancer itself. It's because that cancer is releasing that hormone. So if this is the case, here we have our hypothalamus hormone, corticotropin releasing hormone goes to adrenal corticotropin hormone, which goes to the adrenal gland to produce cortisol and its other hormones. If the adrenal gland is overproducing cortisol on its own, we would have increased cortisol. If there was a tumor in here that was increasing production of adrenal corticotropin hormone, we could have an increase in cortisol for that reason. Or we could have just some side area in the body that's producing this hormone inappropriately. If we have an excess in cortisol, that's Cushing's disease, that means we will have an increase in blood sugar, and we will have a decrease in potassium and an increase in sodium, and usually an increase in water. People have acne, menstrual irregularities, hirsutism, and this is related to an increase in androgens that's also created in the adrenal gland. Muscle wasting, weakness, bone breakdown, and then altered fat metabolism, meaning that we just move where the fat accumulates. And that's the moon face, where the person gets fat accumulation in their face, or the buffalo hump, where people get fat accumulation on their back. All right, and so from slide 52 down, those are information about the other hormones that are created in the anterior pituitary, especially related to secondary sex characteristics. So that's not on the exam, that's just information for you if ever it's needed. So that is the endocrine function that we are going to talk about. Is there any other questions about thyroid or adrenal gland hormones before we move on to kidneys? Does Addison's disease increase risk for dehydration? So if we have an overall decrease in adrenal gland hormones, that means a decrease in aldosterone, which would mean that we could lose sodium and water. So it could lead to dehydration, which is probably one of the contributing factors to the hypotension, besides the overall decrease in cortisol to begin with. So yes, that is true. I'm not sure if you can hear my cat right now, but it wants me to go rub its belly. And I am not. I am busy. Okay, so now we're kidney function. It's just, when you have class at home, that's what happens, I guess. So kidneys are paired bean-shaped organ. They are made of lobules, and each lobule is composed of nephrons, and each kidney has at least 1 million nephrons. I know. That's funny. My dog is always down here too. Right now he's resting, but he does get agitated sometimes too. Right now he's okay. Yesterday I was teaching and I had my computer upstairs, and the dog kept pacing back and forth, and our floors are like pergola flooring. So everyone was like, "Who is pacing?" I'm like, "That's my dog." So there's millions of nephrons. There's a million nephrons in each kidney, and it's organized. These nephrons are organized into lobules, which are our functional unit of the kidney. And each nephron, there are two types of nephrons. Some are cortical nephrons, and some are juxtaglomerular nephrons. It just depends, and here's this picture, on how far down the loop of Henle goes. Lets you know what type of nephron it is. Is a nephron that's primarily within the cortex and just goes down, the loop of Henle goes down just slightly into the medulla, or does, like this one, oops, I lost my drawing finger. So this would be a cortical nephron because it's mostly in the adrenal cortex, just a small amount in the medulla, as opposed to one that the loop of Henle is way down into the medulla. So those are our two types of nephrons. And the nephrons themselves all are divided into these sections, where Bowman's capsule is where there's lots of, that's the filtration part. The proximal convoluted tubule is some reabsorption of water and electrolytes. The loop of Henle is where there's a gradient that's made on purpose that will change depending on antidiuretic hormones. So this is where we control, one of the large areas that we control water absorption. And then the distal convoluted tubule into the collecting duct, which then comes together into all the collecting ducts empty into the renal calyx and then down through the ureter into the bladder. The capillary system supplying the nephron is the glomerulus capillary system and then the peritubular capillary system. The glomerulus is under high pressure on purpose because we are trying to cause filtration. And the peritubular capillary system is low pressure because we want time and the ability to reabsorb if we need to. So the special structure of the glomerulus and Bowman's capsule creates this high ultrafiltration. So the first class, we talked about the forces that favor filtration, what will allow fluid to leave the vessel. And in the nephron, we want the fluid to leave the vessel, to go into the nephron, to be filtered. Everything that's filtered into the nephron in the beginning isn't going to stay there. We are probably going to reabsorb a large portion of water and some of the electrolytes, but we filter it first. And so we create this high pressure system because the afferent limb of the capillary is a wider vessel, sort of like what my patho teacher would have said, like a 4-lane highway into this knot of capillaries, and the exit, or the efferent limb of this capillary, is like a small frontage road. It's much smaller in diameter than the afferent limb, and so we create this bottleneck of high pressure in the glomerulus. And there's Bowman's capsule. And these are very tight together. The interface is very small, so it's easy for diffusion of water. And because we've increased the hydrostatic pressure by creating this, the way the system is, we've created this hydrostatic pressure in the glomerulus, which will favor filtration into the nephron. And so when we talk about kidney disease manifests as decreased filtration. So something is going on that is not allowing the forces to favor filtration like we want them to. So this is a much sort of like we're looking this way. We're taking a cross section right here of the glomerulus to show you that we have the afferent and efferent vessels leaving the glomerulus, and Bowman's capsule is wrapped around that knot, that glomerular capillary inside. And there are, it's hard to see here, but there are podocytes or special bridges or slits between the vessel basement membrane and into Bowman's capsule. So we're trying to make it easy for water to filter through into Bowman's capsule. These purple-like cells are called mesangial cells, and they are supportive cells that allow their sort of scaffolding or help keep the vessels in the right space. And then we can see that these are small slits. So as long as the vessel and Bowman's capsule are healthy, larger structures like protein and red blood cells should not easily come through the capillary into Bowman's capsule. It should just be fluid. That's what we want. We don't want the larger molecules to leave the vessel. The juxtaglomerular complex is, here's that afferent and efferent vessel. Here's the afferent vessel into the glomerulus, and then the efferent vessel on the way out. And there's Bowman's capsule that we're going to allow ultrafiltration into the first part of the tubule. This is where the collecting duct comes up, and there's an intimate relationship between that collecting duct and the vessels themselves. And this special area in the juxtaglomerular complex is that juxtaglomerular apparatus that you may remember we talked about in the cardiovascular unit. Those are the specialized cells that are looking at the concentration of water and sodium in the capillaries as they go in and out of the glomerulus. And it's based on that information whether or not renin will be released, because it depends on the pressure or the amount of fluid that's going into the glomerulus, which our body interprets as, if there's not enough flow into the glomerulus, it must mean that we are dehydrated. And so in order to support our blood pressure, we need the end product of angiotensin II and aldosterone so that we save fluid and sodium and vasoconstrict to bring the blood pressure up, which we know is not necessarily the right answer to a decreased flow into the glomerulus, because it could be related to hypertension, because resistance decreases flow. So hopefully that sounds familiar, because that was from the cardiovascular unit. So the factors that affect glomerular filtration is that capillary hydrostatic pressure and the capillary osmotic pressure, and that should be balanced with the pressures in Bowman's capsule. Yes. So can we say the RAAS occurs, the renin-angiotensin-aldosterone system begins in the juxtaglomerular apparatus? Those particular cells are monitoring the fluid concentration and pressure in the capillaries of the glomerulus, and in response to a decrease in that pressure or fluid concentration, then there will release renin, which starts the whole process. So, concentration of urine, the osmolarity, you're welcome. So what if, depending on what our situation is, if we have more fluid than we need, or we are dry, or the osmolarity of our fluids is low, we're dehydrated, then we can change the concentration of our urine based on the needs of the body. And that is done through a hormone that's produced in the posterior pituitary called antidiuretic hormone. And the action of antidiuretic hormone is to open up aquaporin channels to help water move into the capillary. So we save water, we don't pee it out. Hence the name antidiuretic. And the way that this is done is the way that this works is the osmolarity of the interstitial fluids near the loop of Henle and the collecting duct is monitored for a change in concentration. And if that's present, that is the trigger for the release of antidiuretic hormone to open up the water channels. So here we are after we've filtered, so this is the proximal convoluted tubule. We have water and sodium and chloride in that proximal convoluted tubule. And as we move through and get to the loop, the osmolarity of the extracellular fluid is higher than the osmolarity as we enter the beginning of the loop of Henle. As the fluid moves down, more and more water leaves the loop of Henle. And here you can see that as more water leaves, by the time you get to the bottom of the loop of Henle, the fluid inside the nephron itself is very concentrated. As you move upwards, more water tends to come back into the nephron itself that you would urinate. If this concentration that we've created, this concentration gradient that we created is very high between this area, that is a trigger to release antidiuretic hormone, which will insert water channels and cause the water to go into the bloodstream instead, to stay in the bloodstream. So if depending on how concentrated we get here, that could cause a huge concentration gradient between the outside and the inside, which would trigger antidiuretic hormone to insert water channels. So instead of keeping the water in the nephron, it would put the water in the blood vessel next to it, which is what we would do if we were dehydrated. The other part of the nephron that is important is that we can measure the performance of the nephron or the levels of solutes or substances in the bloodstream based on the concept of renal clearance. So renal clearance, the definition is the volume of plasma that is completely cleared each minute of any substance that finds its way into the urine. And each substance has a percentage of which that will be cleared. We can use renal clearance as a measure of kidney function if we're talking about substances that we know that should be completely cleared every minute. And part of renal clearance is based on transport mechanisms within the nephron. So if this is our glomerulus again, and here's our Bowman's capsule into the proximal convoluted tubule, we would expect that lots of water is filtered through here as well as, so we should get water, we should get urea, which is the leftover metabolic waste of protein metabolism. We should get any extra acid, and we should have some glucose that transfers through here, sodium, chloride, potassium. All those substances should end up in the beginning of this proximal convoluted tubule, and as we work our way through, substances go in and out depending on the needs of the body. We would expect that this urea gets cleared. A large percent of urea should be cleared because that's the protein wastes. The other way that that protein waste can be measured is creatinine, and we would expect urea and creatinine to be cleared from the serum by the kidney. Our whatever water level should be based on the needs of the body and whether or not antidiuretic hormone was released. Sodium, chloride, potassium, hydrogen, phosphorus, all those things will move in and out. We will probably filter the glucose, but would expect all the glucose to return to the kidney because we have a mechanism to do that. So some substances move freely down concentration gradients, like our electrolytes, and some, if they get filtered and we know they need to come back through, are sent back into the bloodstream through protein receptors. And glucose is one of those. We can't just move. If glucose comes out into Bowman's capsule, if glucose ends up coming out, which it should, into Bowman's capsule, then it just can't move freely back and forth, glucose, like some of those other substances do because it's a larger molecule. It can't just move down concentration gradients the same way. So if a lot of the glucose gets filtered, we need it to get back into the bloodstream because we need the glucose for energy production. We wouldn't want to lose it. And so we have a transport mechanism to get glucose back into the bloodstream, and that's another GLUT receptor that will allow glucose to move. Here's the inside the nephron, and here's the bloodstream that will allow glucose to move back in. Here's our glucose transporter. This you'll find mentioned in pharmacology class because that's one of the medications that change how glucose is filtered in the kidney. So the reason why when I would have, if someone would give a urine specimen and if their blood sugar is normal, we shouldn't see any sugar in the urine because I have enough transporter proteins to get glucose back into the bloodstream. But if I completely use all my transport proteins, then I'm going to lose glucose in the urine because I reach my transport maximum. So there's many things that influence renal clearance of a substance. If that substance needs a transporter molecule, then we might lose more of it in the urine if those molecules get flooded, like glucose. Glucose requires a transport protein in order to get it back to the bloodstream. If my glucose level in the filtrate is too high, then I will lose glucose in the urine, which is why you'll see loss of glucose in diabetic patients. So the kidney has many essential functions. It has endocrine functions. We've talked about renin-angiotensin-aldosterone system. We talked about erythropoietin as part of the kidney measures hypoxia, and if the oxygen level is low, that's a trigger for the kidney to release erythropoietin to increase production of red blood cells. Vitamin D, we briefly spoke in the first class about calcium and phosphorus metabolism, and that vitamin D is activated in the kidney and will, under the influence of parathyroid hormone, will change calcium reabsorption or excretion. It's in charge of regulation of electrolytes and acid-base balance. We're eliminating organic ions and medications. We're getting rid of uric acid, so it's part of our purine metabolism, and we're eliminating the protein metabolism waste. So it has many, many functions. The serum creatinine is a way for us to estimate serum function, or to estimate, kidney function. The glomerular filtration rate is much more sensitive than serum creatinine, and some people use that instead. But the serum creatinine level is a way to estimate the functional capacity of the kidneys, because creatinine is one of the byproducts of protein metabolism that should be really completely, almost completely filtered by the kidney. We shouldn't have a very high serum creatinine level. If the creatinine level doubles, then renal function, or the glomerular filtration rate, is probably fallen by half of its normal rate. So that's a 50% loss in nephron capability. If there's a rise in creatinine level to 3 times its normal value, that suggests a 75% loss of renal function. And values of 10 or more, you can assume that you have less than 10% of renal function left. So it doesn't take much of a bump in serum creatinine for you to be concerned about renal function. Because if someone's normal creatinine level is 0.7, then 1.4 means there's a 50% loss of kidney function. So any elevation in creatinine needs to be taken really seriously. And you also have to take creatinine level with a grain of salt, because if it is, no pun intended, if it is a person with low protein stores or small muscles, or an older person, their serum creatinine should be lower in general. And so any rise, a 1.1 for someone who is elderly, is probably worse than for someone who is younger. So serum creatinine interpretation is different if it's a chronic, steady increase versus an acute rise in creatinine. So baseline creatinine level is important if the patient has a history of renal insufficiency or any kind of decrease in filtration. So I would expect, with some of the chronic health problems that we've talked about, like hypertension, hyperlipidemia, and diabetes, there's a decreased flow into the kidney over time, then there will be a loss of nephrons just from that steady decline in perfusion to begin with, and I would expect a steady increase over time in serum creatinine as these chronic health problems persist, which is different than if even somebody who had some baseline kidney dysfunction suddenly develops an acute rise in their creatinine. And if that occurs, then it's important to interpret that creatinine in relation to BUN and to evaluate the person to decide, just like we talked about last class. We talked about how you should look at an elevation in bilirubin in terms of, is this a problem above the liver, such as hemolysis? Is this a problem within the liver that's causing an alteration in the use of bilirubin, or is it related to an obstruction below the liver? We can do the same type of assessment of the kidney. Is this acute rise in creatinine related to a problem above the kidneys, a pre-renal issue, which is usually related to perfusion, an acute change in perfusion? Is this a problem in the kidney itself, where the kidney itself is being damaged, or is this related to an obstruction below the kidney? Why is this creatinine elevated? And we can not just look at the creatinine, but at the ratio between the BUN and creatinine to help us make that decision. And we can look at the urine itself. Is there loss of normal nephron cells, and has the kidney lost its ability to concentrate urine in the setting of fluid loss? If the normal BUN is 10 to 20 and the normal creatinine is about 1, the normal BUN to creatinine ratio should be about 10 to 1. That's what we're kind of expecting it to be. If the BUN rises a lot, meaning there's an increase in blood urea nitrogen in the body as well as creatinine, where the blood urea nitrogen can be 50 and the creatinine is 2, then it's 50 to 2, which could be, it's this is a very high ratio. So if it's greater than 15 to 1, that usually coincides with a pre or post renal dysfunction. Whereas a smaller change in BUN with a large change in creatinine is an intrarenal issue, which we'll talk about coming up. So renal pathology. Renal failure is a condition which the kidneys fail to remove the metabolic products in our body. So we've lost filtration. And it could be a renal disease, a systemic disease, or some kind of non-renal issue. If it's greater than 15 to 1, it could be either a pre-renal disorder or a post-renal disorder. We'd have to look at the other things going on as well. So types of renal failure can be acute, which is what we were starting to talk about, which is reversible if it's treated early. Sure, if it's treated early. And that would allow us the greatest recovery is if we find the person is having an acute rise in creatinine, meaning they're having a decrease in filtration, and we reverse the cause. Chronic renal failure is irreparable damage to the kidneys that develops slowly over the course of many years, and that's related to chronic health issues. And anyone who's developing chronic renal failure will be very sensitive to any issue with the kidney. So they're going to be at increased risk for acute renal failure. And if they get acute renal failure, will be less likely to recover from that. All right, so acute renal failure. Pre-renal causes of acute renal failure are anything that will cause essentially dehydration or shock related. So if we have less volume, then we're going to have decreased flow into that capillary, and there's going to be decreased filtration because there's an overall decrease in hydrostatic pressure. So either it's because of a shock situation or dehydration or decreased renal perfusion, but it's usually this issue. Post-renal means there's some kind of obstruction below the kidney, either at the ureter or bladder outlet. So causes of urinary tract obstruction could be that there's some kind of anatomic issue. Could be a stone. Pregnancy can lead to obstruction of ureters. Benign prostatic hypertrophy, scarred from continued infections or inflammation, a tumor. So if you develop obstruction, the damaging effects of urinary obstruction is related to the stasis of urine, which can lead to infections, and this back pressure, which interferes with renal blood flow and start to destroy renal tissue. And you can see or understand that if here's my lovely glomerulus, and here's Bowman's capsule, if there's a backflow of fluid because of an obstruction down the ways, then there's going to be an increase in hydrostatic pressure in the nephron that will probably be greater than what's going on in the glomerulus. So I will not be able to filter. There's a loss of the forces of filtration if the hydrostatic pressure is greater in the nephron. So there will be no filtering. The fluid will just keep going through, which means I will have an increase in especially potassium, which is filtered, increase in water, increase in urea and creatinine in those products that are supposed to be filtered by the kidneys. And one of the manifestations of the urinary obstruction depends on the site and the cause of the obstruction. If the patient has benign prostatic hypertrophy or enlargement of the prostate, then they're going to have difficulty emptying the bladder, urinary hesitancy, urgency. If they have a kidney stone that's causing trouble in emptying the ureter, that's very painful. And if they have, it depends on what the cause is, but the common symptoms are pain, increased risk of urinary tract infection due to urine stasis, and potential kidney dysfunction. So we'll talk about stones before we take another little break. Kidney stones, they're a crystalline structure that form from components of the urine. So in order for a stone to develop, there has to be an environment in the nephron that favors crystallization. And it starts as a nidus, or something that begins formation. This would be crystals combining together as the nidus. And if there is an imbalance in crystal causing and crystal stopping, then you're going to have more crystals develop. So factors that influence formation of kidney stones are the concentration of stone components, the ability of the stone components to come together, and the presence of substances that are supposed to inhibit stone formation. So there is supposed to be a balance between crystal promoters and crystal inhibitors. So there should be a balance between calcium and magnesium, and a phosphate and pyrophosphate. If there is more urinary promoters, more calcium and oxalate and urate in the nephron, then there will be a promotion of crystals that will start out. Here's the Randall's plaque. We start out with a small amount of crystal, and then it sort of adds together. We would hope that we would have enough of the urinary inhibitors that this wouldn't happen. So we will stop there. It's 8:51, so we'll reconvene at 9 o'clock and finish out the kidney disorders. So let me pause. Okay, so we're getting to the end here. Let me just be sure I'm sharing. Recording, we're good. So causes of intrinsic or intrarenal causes of renal failure would be some kind of either prolonged ischemia to the kidney itself, exposure to certain drugs. The one I always think there's certain antibiotics that are definitely hard on the kidneys, like vancomycin, an infection, causing an acute infection to the kidney itself, or some kind of obstruction in the nephron itself. Phases of acute tubular necrosis. There is a onset or initiating phase, then a maintenance phase characterized by a marked decrease in glomerular filtration rate and hopefully recovery that takes place. So if you had a patient with an acute rise in BUN and creatinine, or in creatinine, you would evaluate it alongside the BUN and expect that the ratio of BUN to creatinine will be increased or 15 or greater in the setting of pre or post acute renal failure, which would be obstruction or dehydration most of the time. An intrarenal problem will have a lower ratio. The BUN and creatinine ratio will be usually 1 to 10 or less. The creatinine will rise higher than the BUN. Obviously the patient will have other symptoms going along with it to help you put that together. If you saw on that slide about urinary tests, there were also tests to see if there were any kind of pieces of debris in the urine, different cells in the urine, as well as the kidney's ability to concentrate, which I would expect that the ability of the kidney to concentrate will be less in the setting of an intrarenal issue. So those are some of the ways that you can look at those tests. Chronic renal failure is obviously different. It is a slow rise in creatinine over time related to a decrease in number of nephrons. And once this happens, there isn't any turning back. You're going to change your baseline creatinine over time. You would hope that if it's possible to manage some of the chronic health problems like diabetes or hypertension, then at least you preserve the kidney function that you have. So stages of chronic renal failure start with some renal insufficiency and end with end-stage renal disease. And these stages are usually based on GFR with a mild reduction to kidney failure and the need for replacement, either with dialysis or transplant if possible. So common causes of chronic renal disease are listed here, like we've been talking about, are hypertension, diabetes. There's some autoimmune disorders that start to break down the kidneys, cancers, inflammation of the glomerulus or obstructions of the urinary tract over time. Polycystic kidney disease is a genetic disorder that causes, that's what this picture is, that causes cysts to develop in the kidneys that kind of take over the parenchyma and put pressure on the nephrons. So cystic disease of the kidney is fluid-filled sacs or segments of a dilated nephron that increases intratubular pressure and changes in the basement membrane of renal tubules predisposed to cystic dilation. So there is a genetic component to it. Some people are born with it, and some people have the recessive gene, and so later on it happens. So the genetic change is what leads to changes in the basement membrane of the renal tubules. So we've always talked about epithelial cells. In the kidney, they have like a brush border. So I should actually probably draw them that way. No. They're sort of like this, the kidney cells. Different epithelial cells laying on a basement membrane. So if there's some kind of dysfunction in the basement membrane that allows for cysts to develop, so a fluid-filled sac, if that cyst gets larger and larger in the nephron, then it's going to obstruct the nephron, which means there's only so much fluid that will be able to filter before there's going to be an increase in back pressure and will start to decrease filtration. So if this happens in a few nephrons, we might, over time, as more nephrons are affected, we might notice a change in filtration. But as this goes on and infects more and more nephrons, these cysts then put pressure on the vessels that are trying to support the nephrons, which will start to lead to ischemia and eventually will lead to renal failure. It is possible to develop a simple cyst in the kidney. Lots of people have cysts in the kidney and they don't even realize it until they have a CT scan for something else. And one or two simple cysts is not completely abnormal. You can develop medullary cystic disease, which means you develop cysts in those medullary nephrons, or polycystic kidney disease, which means you develop cysts in all of your nephrons. So that's one reason for chronic renal disease. You could have a trouble in the glomerulus itself, and there are several diseases. Nephrotic disease means there's a change in the actual glomerulus. There are several types of nephrotic diseases, primary diseases that people would be born with. where the glomerulus becomes, that interface between Bowman's capsule and the glomerulus becomes inflamed, or there's changes to it that are related to autoimmune disease, or over time diabetes and things like lupus disorder can change the glomerulus as well. And if that happens, there will be thickening of the basement membrane and immune complexes that will bind there, eventually leading to an increase in permeability at a greater size of those slit pores. So if I were to draw that, so here's the glomerulus and the Bowman's capsule. One of those first pictures we showed, there was the blood vessel and with those endothelial cells and the basement membrane, and then right next to the basement membrane were those slit pores, where those podocytes were, a Bowman's capsule. So one way would be if I developed a glomerular nephritis. This can happen actually from strep throat that's not treated. The immune system is activated, we create antibodies. The antigen, the strep antigen and immune complexes can get caught here in the basement membrane, and eventually, because they're calling in macrophages and those phagocytic cells, we will create holes in the basement membrane, making it easier for larger compounds to come through into Bowman's capsule, like proteins and red blood cells. Or it could be changes in the quality of the basement membrane from other genetic issues. But what we're eventually causing is for it, this destruction makes it easier for proteins and red blood cells to get through. So people who have glomerulonephritis will end up with hypoproteinemia because the protein is being lost in the urine. And so the urine itself will look like a frothy, have kind of a weird odor as you're losing that from in the urine. So if I lose, the reason the patient is very prone to edema is if they have less protein inside the vessel, decreased plasma oncotic pressure. Because of that, that increases filtration into the interstitial space. So they end up with more edema, and that's the thing that people will notice, is a change in the color and look of their urine with extra edema. You can get defective glomerular basement membrane and that mesangial, that supportive tissue to the blood vessels in the glomerulus, just because of diabetes. That's diabetic glomerular sclerosis, because glucose gets incorporated in there and the cells change related to too much angiotensin. And again, the same thing occurs, is we lose proteins and red blood cells in the urine, and we end up with edema. So over time, the clinical manifestations of chronic renal disease have to do with a problem with all the functions of the kidneys. So we know that the kidney is supposed to release nitrogenous waste, get rid of urea. So if the person cannot filter those wastes, they end up with something called azotemia or uremia. They have an increase in those wastes in their bloodstream, which can affect their mental function. It can also be uncomfortable because some of those proteins will try to leave through the skin, so the patient will have like a different feel to their skin. It can be very itchy and uncomfortable. They will have alterations in water, electrolyte, and acid-base balance. They will especially be more prone to retention of potassium, because excretion of potassium is a very important job of the kidney, as well as an increase in water retention. The kidney is in charge of excretion of calcium and phosphorus depending on the needs of the body and the parathyroid hormone. If the kidney isn't able to do that, then there can be an increase in phosphorus and calcium in the bloodstream, which can change the way our bones function, the strength of our bones. We will have anemia because of a decrease in production of erythropoietin. We know that we will increase the likelihood of hypertension due to the release of angiotensin II. And these disorders are related to changes in the urea in the bloodstream. So we have a lot of chronic health conditions that will take place when someone has renal disease. And so the main takeaway from this is whatever is going on between the nephron and the glomerulus, we want filtration to favor fluid moving into Bowman's capsule into the nephron. And if that can't happen, then the fluid is stuck inside, and we would expect that things that the kidney is in charge of clearing will increase in the bloodstream. And if the patient develops chronic renal failure or chronic renal disease related to their other health problems, then we have to be especially vigilant to any change in their creatinine, because we need to reverse that right away so they can recover. So that's the end of our lectures. Does anyone have any questions? I will process these recordings and put them up. The study guide is up. I have to put the case study up. Yes, the kidneys are, when I worked in primary care, and what I highly recommend to anybody who works in primary care is that anytime your patient leaves the hospital, you want to see them right away, because the thing that gets messed up in the hospital a lot is the kidneys. Because during the acute illness, the kidneys are like the last on the list. And then when the person seems like they're feeling better, we have to figure out what to do with the kidneys. And anytime one of my patients got discharged from the hospital, their creatinine and their medication were all messed up. You're welcome. I'm excited for next class where I can just sit back and listen. I know you guys are really looking forward to getting to talk. Thank you guys. Thank you for your patience. I know this isn't like the most ideal setting, but I think we got it to work for ourselves. And it is always difficult. Yeah, I mean, we still get to talk through it, and there's opportunity for questions. Um, yes, see you next week. I am really looking forward to it. And I always think that anyone who takes patho in the summer has an extra ounce of courage and should be given a little extra nod of respect, because it is definitely a lot of work to be crushed in to 8 weeks instead of the longer. Yay, yes, you're almost through. Yay! Yes, more PSD, more things you'll have to work through in your next classes. All right, you guys, take care. See you next week. You are very, very welcome.